Hello guys, this is a question paper of anatomy from Atal Bihari Vajpayee Medical University for the students admitted in MBBS 2021. This paper was held in January 2023. So it is of main exam. This question paper is paper 2 part 2. So this was of 50 marks. So here you seeing is the first question, which is a long answer question, which is subdivided into 6 plus 4 plus 5 is equal to 15 marks. The question states that a patient comes with the complaints of jaundice, vomiting, epigastric pain, dyspepsia. On examination, he was diagnosed to have carcinoma head of the pancreas. Now, the questions attached to this are: what are the parts of the pancreas and its relation? Explain the development of pancreas and its anomalies. Explain its blood supply and tributaries of portal vein. So there you seeing it is not a clinical question, not a case-based scenario question, because you have nothing to do with whatever has been written above. And the diagnosis also been already mentioned. And you've seen the subparts, they're not related to whatever is explained above. So it's simply an essay type question or a structured long question on the topic pancreas. So in 6 marks, you have to write about what are the parts of the pancreas. You know, it has a head, a neck, a body and a tail. And the head part also has an uncinate process. That will give you 2 marks. Then describing the relations of each of these parts will make you add up 4. That is 6 marks. So you should also see the marking pattern and accordingly you have to write. And remember, in gross anatomy, relations are really very important because that is what will help you in surgery. So in the beginning, you can describe the pancreas as a whole, that it's where it's located, what's its shape, size. Remember, it's a J-shaped organ with its longitudinal axis around 15 to 20 centimeters, and its left end is a little elevated than its right end. Means the head is lower than its tail end. Now talking about its head of the pancreas is towards the right and is encircled, or it's in relation to the duodenum laterally. So this duodenum, second part lies towards the right, third part lies below to the head, and fourth part lies on the left side of the uncinate process, while its first part of duodenum is actually in anterior relation to the head of pancreas. And the anterior relations, you can write that, of course, I just told you this is the first part of the duodenum, then the transverse colon, and of course the loops of the jejunum also will be overlying to it anteriorly. Remember that pancreas is completely a retroperitoneal organ, and over to this is the lesser sac of peritoneum. So it's not in direct relation to these structures anteriorly. In between, it has a space that's called omental bursa. While in posterior relation, it will have this common bile duct in its upper portion, inferior vena cava, the right renal vein, the right crest of the diaphragm, and behind the uncinate process, if you see, there will be this abdominal aorta, the right crest of the diaphragm. And what lies anterior to the uncinate process is the superior mesenteric vessels, the vein and the artery. Okay. Then talking about the neck, what lies anterior to the neck? It will be the pyloric end of the stomach, because from here it continues as the first part of the duodenum. And first part of the duodenum, I told you, it's directed backwards, upwards, and towards the right. So pylorus lies in front of the neck, and first part of the duodenum lies in front of the head of pancreas. What lies behind the neck of pancreas, is the termination of the splenic vein and superior mesenteric vein, which join to form the portal vein. So remember that the portal vein is being formed behind the neck of pancreas. Now talking about the body of pancreas. So body of pancreas, is lying behind the omental bursa. It is a part of the bed of the stomach, and the splenic artery runs above the superior border of the pancreas, and it has a tortuous course, reaches towards the tail, from where it enters the hilum of the spleen. while the splenic vein runs behind the body of pancreas, reaching towards the tail. So, in its course, you should know it will also cross the abdominal aorta. The body of pancreas lies in front of the abdominal aorta. And from there, at the level of L1 lower border, there is this superior mesenteric artery arising. So remember that the body of pancreas and the splenic vein lies anterior or above the superior mesenteric artery, while the left renal vein will be passing below to the superior mesenteric artery, and even the uncinate process will be lying below to the superior mesenteric artery. Then, of course, the left crest of the diaphragm will be there, the left renal vein, left renal artery, the left kidney, the left suprarenal gland. All this will be behind the body of pancreas. Anterior to it, as I just told you, will be omental bursa and the stomach. While talking about the tail of pancreas, I believe I explained this in paper 2 part 1. There was an MCQ related to it. So remember that the tail of pancreas is a content of the linorenal ligament through which it reaches towards the hilum of the spleen. One thing more important here is, like in case of splenectomy, the surgeon has to take care of the tail of pancreas. Remember that tail of pancreas has the maximum number of beta cells that secrete insulin. So compromising with the tail of pancreas will lead to diabetes or hyperglycemia. Now part B of the same question. Explain the development of pancreas and its anomaly. So remember that pancreas develops by two pancreatic buds, a ventral pancreatic bud and dorsal pancreatic bud. These buds arise from the distal portion of the foregut, which forms the upper half of the second part of the duodenum. So the ventral pancreatic bud develops ventrally from the distal end of the foregut, where it joins the proximal portion of the midgut, while the dorsal pancreatic bud grows posteriorly in the dorsal mesentery. Later on, with the rotation of the midgut loop, when the duodenum comes to settle on the right side of the head of pancreas, along with that, the ventral pancreatic bud also rotates laterally towards the right and reaches posteriorly to join the dorsal pancreatic bud. So the pancreas is formed by both the ventral and dorsal pancreatic buds. So obviously it will be endodermal in origin. The dorsal pancreatic bud is a larger bud and contributes to the formation of the upper portion of the head of pancreas, neck of pancreas, body and the tail of pancreas, while the ventral pancreatic bud contributes to form the lower portion of the head and the uncinate process of the pancreas. Now about its duct system. Both these pancreatic buds, they also have a duct formed within. The main pancreatic duct is formed within the dorsal pancreatic bud, which drains the tail of pancreas, the body, neck and the upper portion of the head of pancreas. And in the juxtaduodenal portion, right, where it is about to drain into the duodenum, there it joins the minor pancreatic duct, which is the duct of the ventral bud. So you can say that the proximal portion of the major pancreatic duct is formed by the duct of the ventral pancreatic bud, and the rest of the portion is being formed by the duct of the major pancreatic duct. And this main pancreatic duct opens at the major duodenal papilla around 8 to 10 centimeters from the pyloric end. This major pancreatic duct is also called duct of Wirsung, and the tributaries of this major pancreatic duct are aligned in V-shaped manner, directed towards its flow from the tail end towards its opening in the duodenum. So that V-shaped arrangement of the tributaries of the major pancreatic duct is a special pattern, and it's called herringbone pattern. While the minor pancreatic duct is the juxtaduodenal portion of the duct of dorsal bud, which does not joins the duct of the ventral bud. So that stays in its position and drains 2 centimeter above the major duodenal papilla, and that opening is called the minor duodenal papilla, which is around 6 to 8 centimeters distal to the pyloric end of the stomach. This minor pancreatic duct is also called accessory pancreatic duct and also called duct of Santorini. Now, talking about the anomalies, first of all, you can mention about the annular pancreas. Normally, you know that the head of pancreas is surrounded by the duodenum on the right side, and the head and neck of pancreas embrace the commencement of the portal vein. Now, what happens in an annular pancreas? This head of pancreas is going to embrace the second portion of the duodenum, and this happens because of the bifurcation of the ventral pancreatic bud during the early embryogenesis. That's why pancreatic tissue comes to surround this second part of the duodenum from all the sides, and that leads to the obstructive symptoms like jaundice, portal hypertension, dyspepsia, epigastric pain, all type of complaints mentioned above. Similar is going to happen in case of carcinoma head of pancreas. So this is one anomaly, and you can also mention about the accessory pancreas. Actually, accessory pancreas is a minor amount of pancreatic tissue being developed elsewhere, like within the duodenum, jejunum, ileum, mesentery, or in the Meckel's diverticulum. Such tissues might lead to cause ulcerations wherever they are present. Then another one is inversion of the arrangement of the pancreatic ducts. Like the major pancreatic duct will drain into the minor duodenal papilla, while the accessory pancreatic duct which will drain into the major duodenal papilla. In this case, the accessory pancreatic duct will be a larger duct and will drain the majority of the pancreatic secretions at the minor duodenal papilla. Next is explain the blood supply and the tributaries of portal vein. So there are two separate parts in this question. Because it's of 5 marks, you can consider that blood supply may be of 2 marks and tributaries of portal vein can be of 3 marks. So talking about blood supply of pancreas, basically when they ask blood supply, it means actually they're asking is the arterial supply. You may or you may not write the venous drainage. But if you have time, you can add up a diagram drawing the venous drainage as well. But blood supply, supply is afferent. So afferent is the arterial system. So as you know that the duodenum is formed by the distal portion of the foregut and the proximal portion of the midgut. So it has blood supply from both the celiac trunk as well as superior mesenteric artery. Same is going to happen with the pancreas because pancreas also is arising at the junction of foregut and midgut. So the blood supply of pancreas will be from both the celiac trunk as well as from the superior mesenteric artery. So the major supply for the pancreas is through the splenic artery, which you know is the largest branch of the celiac trunk. This splenic artery runs along the upper border of the pancreas in a tortuous course, or to be more precise, runs along the posterior-superior border of the pancreas. And remember that the celiac trunk arises just above the tuber omentale of the pancreas. It's a upwards projection from the body of pancreas just below to the origin of celiac trunk. So from there onwards, this splenic artery continues its course towards the tail end, and along its course, it gives several minor branches to the pancreatic tissue, but a major pancreatic branch is called arteria pancreatica magna that supplies the major portion of the body of pancreas. Similarly, towards the tail end, it also gives another major branch, and that is called arteria caudate pancreatis. And then this artery, along with the tail of pancreas, reaches into the linorenal ligament to supply the spleen and left lateral portion of the fundus and body of stomach, while the upper portion of the head of pancreas is supplied by superior pancreatico-duodenal artery. This superior pancreatico-duodenal artery is a branch of the gastro-duodenal artery which runs behind the first part of the duodenum, and this gastro-duodenal artery is a branch from the common hepatic artery which is a branch from the celiac trunk. Now the lower half of the head of pancreas and the uncinate process gets blood supply from the superior mesenteric artery via the inferior pancreatico-duodenal arteries. These two arteries, superior and inferior pancreatico-duodenal artery, anastomose with each other at the level of head of pancreas, or you can say on the left border of the second part of the duodenum. So this is how the blood supply determines that the duodenum and pancreas have developmental components from both the foregut and midgut. Now, talking about the tributaries of portal vein. So, portal vein, is formed by two major tributaries. One is the superior mesenteric vein, which drains the structures derived from the midgut, and the splenic vein. Remember that splenic vein also receives a tributary called inferior mesenteric vein, which drains the structures derived from the hindgut. So the superior mesenteric vein and splenic vein join together behind the neck of pancreas to form the portal vein. And remember, the length of portal vein is around 8 centimeters. So this portal vein commences behind the neck of pancreas and ascends upwards obliquely towards the right, passing behind the first part of the duodenum and then continuing its course within the lower free border of the lesser omentum, which is formed by the hepatoduodenal ligament, and thereby it reaches the porta hepatis to divide into right and left branches to supply the right and left lobes of the liver. Remember that it is a vein which also has branches. Normally, veins have tributaries, but here in this case, remember that this is the vein which also has branches. Now, talking about the other minor tributaries of the portal vein. One is superior pancreatico-duodenal vein, which drains towards the right side of the portal vein, draining the head of pancreas and the duodenum, the upper portion. Then on the left side of the portal vein, there are two tributaries. One is the left gastric vein and the other is the right gastric vein. Remember that the right gastric vein itself also receives another tributary, and that's important, and that is called pre-pyloric vein of Mayo. This pre-pyloric vein of Mayo is important because it's a communication between the right gastroepiploic vein and the right gastric vein. And right gastroepiploic vein drains into the superior mesenteric vein. This pre-pyloric vein of Mayo is lying anterior to the pyloric region of the stomach. Actually, it lies in between the pyloric antrum and the pylorus. There is a groove on the surface of the stomach which lodges this pre-pyloric vein of Mayo. You can learn all this also in the venous drainage of the stomach. Then the left gastric vein, which was draining onto the left side of the portal vein, it also receives tributaries from the lower end of the esophagus. Remember, these are the esophageal veins which were anastomosing with the veins of the esophagus draining into the azygous system of veins, forming a portocaval anastomosis over here. In case of portal hypertension, that leads to esophageal varices. So both right and left gastric veins, they run along the lesser curvature of the stomach within the lesser omentum. Then this portal vein reaches the porta hepatis. As I told you, it was giving its right and left branches. Obviously, the right branch will be a larger branch. Larger means wider and shorter, while the left branch of the portal vein is longer and narrower. I hope this reminds you of something similar in the thorax, and that was the bifurcation of trachea. Same is here. So the major blood reaches into the right lobe of the liver, and that is from the superior mesenteric vein. So that's the reason that toxic and infective substances which are absorbed from the small intestine, like the amoebic cysts, hydatid cysts, they are carried away to the right lobe of the liver. And so right lobe is a common site for infective and toxic changes like amoebic abscess, hydatid cyst. While the blood from the inferior mesenteric vein via the splenic vein reaches to the left lobe of the liver through its left branch. So the blood being absorbed from the large intestine that is lacking in amino acids is being sent to the left lobe of the liver by the left branch of the portal vein, leading to fibrosis or cirrhosis of the left lobe of the liver. So there is a streamlined flow of blood in the portal vein. By the way, this right branch of portal vein also receives a tributary, and that is called the cystic vein, draining the extrahepatic biliary apparatus, mainly the gallbladder. And one more thing to add here is the tributaries of the left branch of portal vein. Those are the paraumbilical veins. draining the subcutaneous tissues around the umbilicus, and these veins run into the falciform ligament to drain into the left branch of portal vein. And remember, the subcutaneous tissue and the skin around the umbilicus is also being drained into the systemic veins, the superior and inferior epigastric veins, then the cutaneous tributaries of the postintercostal veins. So there is also a portocaval anastomosis between the paraumbilical veins and the systemic veins of the umbilicus. In case of portal hypertension, this leads to a communicating channel, and that brings about a sign that is called caput medusae. Now listen carefully. Whatever I am telling you, all the elaborated details, this might be boring, of course, because this is not everything has to be written there in the question being asked. But my purpose is to give you all the relevant information so that this video might be helping you in your future exams. Similar questions, similar MCQs might come across maybe in your NEET PG exams as well. And remember, learning anatomy with the books in front, with the diagrams in front, is a volatile thing that doesn't stays in your mind. So the better way is you read it from the book, see the diagrams, and then close the book and listen to what I'm saying. If you can listen and imagine, then that's the best way to retain it for a longer time. Okay? Question number 2, short notes questions. Here you have to write within 500 words. These are of 5 marks each. So, briefly write about walls, content, and clinical applied of sub-sartorial canal. So, this sub-sartorial canal is also called Hunter's canal or adductor canal. Adductor because this canal is present on the middle one third of the thigh on the medial side. So this is a triangular intermuscular space seen in a transverse cut section of the thigh. It extends vertically from the apex of the femoral triangle and downwards, leading to the opening in the adductor magnus. That's a bigger opening of adductor magnus, the lowest opening, and that's called hiatus magnus. That much is the vertical extent. But in a cross section, you'll find it is a triangular space. So when it's a triangle, it'll have an apex and a base. Apex actually is towards the linea aspera and the base is towards the medial side. So it will have 3 boundaries. One will be anterolateral, the other will be posteromedial, and the third will be the medial boundary. This anterolateral boundary is formed by vastus medialis in its entire length, while the posteromedial boundary is formed by 2 muscles. In the upper portion, it's adductor longus, and in the lower portion, it's adductor magnus. The base of the triangle or the medial wall of the triangle is actually formed by a fibrous septa connecting the anterolateral and the posteromedial walls. That's a strong fibrous membrane over to which lies this sub-sartorial plexus of nerves. And remember this fibrous septa which is forming the base of this triangle. Base I am saying because it's opposite to the apex in a transverse section. Otherwise, longitudinally, if you'll see, it's also said to be the roof of the adductor canal because it's superficially placed on the medial side. And there's a muscle which overlies to this fascial roof of this triangular space, and that muscle is called sartorius. And that's why you get this name sub-sartorial canal. So that sub-sartorial plexus of nerves lying within this roof is actually formed by the terminal branches from the anterior division of obturator nerve, saphenous nerve also, medial cutaneous nerve, the thigh, which is a branch from femoral nerve. Even saphenous also is a branch from femoral nerve. The sub-sartorial plexus supplies the skin and the fascia on the medial side of the thigh. You will also have to draw diagrams explaining whatever you are trying to express. Now the major contents here are femoral artery and femoral vein. And you also have to specifically describe the relation between these two structures, that which is medial, which is lateral. So remember that femoral artery, femoral vein, they have similar relation in the femoral sheath and in the lower portion of popliteal fossa, that the artery is lateral, vein is medial. And this relationship gets reversed in the adductor canal, that the artery comes to lie medial and the vein becomes lateral. So in the adductor canal, femoral artery lies medially to the femoral vein in the center portion of this adductor canal, because this relationship is changing from above and will again change down towards the popliteal fossa. So I'm talking is about the middle portion of the adductor canal. Other contents here are the saphenous nerve. As I told you, it's a cutaneous branch arising from the posterior division of femoral nerve. Then there will be nerve two vastus medialis, the branches arising from both the anterior and posterior divisions of the obturator nerve, medial cutaneous nerve thigh, the lymphatics as well. All this you're going to find here. So artery, vein, nerve, lymphatics you've described. There will be loose areolar connective tissue filling up the spaces. And one important thing, don't forget about mention, apart from the muscular branches given out from this femoral artery here, because at the lower limit of this adductor canal there's hiatus magnus, and after emerging out from there, this femoral artery will now be called popliteal artery. So they can sometime ask you like which is the last branch of femoral artery. So that means the last branch of the femoral artery will be given out in the sub-sartorial canal, and that is called the descending genicular artery, which reaches down to supply the knee joint. Another important point is that this descending genicular artery gives a branch which accompanies the saphenous nerve, and that is called saphenous artery. So you have a saphenous nerve, saphenous vein, as well as saphenous artery. Saphenous artery is a branch of descending genicular artery, which is the last branch of the femoral artery in the subsartorial canal. So you've described of the walls, the contents, and clinical and applied anatomy. You can write the very important point regarding this, and actually, why it's called Hunter's Canal. The reason is this: John Hunter was a British based anatomist and a surgeon. He created a landmark in the history of vascular surgery in those old times. While he had to operate upon the aneurysm of the popliteal artery, so he ligated the femoral artery here in the adductor canal to prevent bleeding while doing the surgery. So since then, this has been of use. Next is ovarian fossa. So ovarian fossa is a peritoneal fossa which lodges the ovaries in the lateral pelvic walls. So the parietal peritoneum lining the lateral pelvic wall creates a depression there to lodge the ovaries. Now this fossa is anteriorly limited by the umbilical arteries in embryonic and fetal life. Later on, this anterior limit of the ovarian fossa is called the medial umbilical ligament. That's because of the remnant of ovarian artery. However, the proximal portion of this artery persists in the form of superior vesicular artery. So that's the anterior limit of ovarian fossa, and posteriorly the boundary here is being formed by the ureters, the pelvic portion. Remember, all these structures, they are covered by parietal peritoneum. And in the lateral wall of the ovarian fossa, there is obturator nerve and vessels passing. So you can say what lies in lateral relation to the ovaries is the obturator nerves and vessels covered by the parietal peritoneum. And the ovaries are suspended here in this ovarian fossa with the help of mesoovarium, which is the fold of peritoneum from the upper dorsal portion of the broad ligament. You should also draw the diagrams in support of your explanation. Next is explain the basis of structural abnormalities of chromosomes. This is a 5 marks question from genetics. So structural abnormalities of the chromosomes, actually this happens when at the time of fertilization, maybe an accidental, mutational, or maybe during the early developmental stages of embryogenesis. This happens when the part of an individual chromosome is either missing, maybe the short arm or a long arm, or might be a segment out of that is missing, or might have an additional portion that's called an extra contribution in a chromosome, or maybe there is switching between the sister chromatids. The part of the chromatids might get exchanged. So switching between the chromosomes can be there. Then a segment of the chromatid might get turned upside down, right? So these are the few types of structural abnormalities which are seen in chromosomes. The examples of this include deletions, that's I told you is missing a portion of the chromosome. Translocations means switching between the chromosomes. And inversions is segment of chromosome gets attached upside down. Duplications might also be there. Sometimes a ring chromosome might be formed. And isochromosomes, remember, if there is a transverse splitting of the centromere, sometimes what happens is during the spindle formation by the microtubules during the metaphase of the cell division, and while this continues as anaphase, in the anaphase of mitosis, the centromere splits longitudinally so that the two sister chromatids get separated with their long and short arms to the opposite poles. This happens in both meiosis 2 as well as in mitosis. But if this centromere is split transversely, what will happen is the two short arms will reach to one side and the two long arms will reach to the other side, means the two daughter cells will receive two different type of chromosomes and the chromosomes will become metacentric. Such type of chromosomes are called isochromosomes. You can quote an example of the deletion or the missing type of chromosome is the Cry-du-Chat syndrome, where a portion of the short arm of fifth chromosome, that is P arm, we call the short arms as P and the long arm is called Q. So this Cry-du-Chat syndrome is also called 5p minus syndrome. अब 5 साल के बच्चे से कुछ ले लोगे तो वो तो रोएगा ही. So fifth chromosome deletion of short arm is called Cry-du-Chat syndrome. Now here I am adding a little more information which will help you in your future MCQs. Edwards syndrome is due to an additional chromosome, and that is extra 18th chromosome. E for Edwards, E for 18. That is autosomal trisomy of the 18th chromosome called Edwards syndrome. Similarly, if there is extra 13th chromosome, that is called Patel syndrome. Patel syndrome is trisomy of 13th chromosome. कुछ लड़के 13 साल से ही लड़की पटाना शुरू कर देते हैं. So extra 13 chromosome leads to Patel syndrome. I know this is not a good mnemonic, but my purpose is somehow to make you remember the things. Maybe you can make a better mnemonic for this. Similarly, trisomy of 21st chromosome is very common. You must be knowing that's called Down syndrome. Also called mongoloid syndrome or mongoloid idiocy. In case of allosomes, there is also called triple X syndrome. Extra X in case of females will be a triple X syndrome, but an extra X in a male will be XXY, and that is called Klinefelter syndrome. Similarly, if there is only one X chromosome in a female, means like there is missing of X chromosome. So we will call it as a female with only X chromosome. The monosomy of X is called Turner syndrome. So all this you can write there in this question. Then there are short answer questions where you have to write less than 100 words, and these are of 2 marks each. So you have to be very precise in explaining them. First here is explain pes planus or the flat foot. Now this pes planus again is a congenital problem when there is not much arching on the sole. The longitudinal and the transverse arches are not well formed. So what happens is the sole appears flattened. So when a person walks, there is hardly much arching. So that exerts, the problem here will be that the weight of the body will be shared back when a person jumps, because this arches of the foot actually are shock absorbers. This also will lead to walking and fatigue problems. The best way here is physiotherapy if it's diagnosed very early. Physiotherapy means like just compressing with your hands the foot of newborn, maybe an infant, but later on in the school going age group, such children can be advised to wear special modified shoes in which the sole is elevated in between, in the middle. So while wearing such shoes with convexity above, gradually this can lead to remodeling of the soft bones of a child, so that by the time he or she attains the skeletal maturity, there is gradual development of the arches of foot. Next is about types of epithelium. a 2 marks question on histology. Now this question is on general histology. So ideally this should have been asked in paper 1. So epithelium, you'll have to describe that it's a covering tissue which covers the structures, the body parts from outside as well as inside, forming the lining of the glands, the viscera from inside as well as from outside. Then according to its use and functions, they're of different types: simple and compound. Simple means when there is a single layer of cells overlying to a basement membrane and all the cells are touching the basement membrane, then such an epithelium is called a simple epithelium. And if there are multiple layers of the cells, of which only the basal cells are attached to the basement membrane, however, the upper cells, the upper layers of the cells, they do not touch the basement membrane. Such layers are called stratified epithelium or compound epithelium. And if on microscopy it appears that the cells are in multi-layered but all the cells are actually touching the basement membrane, then such an epithelium is called pseudo-stratified epithelium. So if to describe this, then under the heading of simple epithelium, you can describe that they are simple squamous, simple cubical, simple columnar, given examples of each. Right, I believe you know them. Simple squamous, you can include endothelium, mesothelial lining of pleura, peritoneum, serous pericardium, loop of Henle, lung parenchyma, the lining epithelium of the alveoli of the lungs. Simple columnar is actually a glandular epithelium found in the glands, the exocrine as well as the endocrine glands in a resting stage. That's simple cubical. Simple columnar is actually the active secretive phase of the glands as well as the lining epithelium of the uterus, stomach. But at certain places, these simple columnar cells, they have finger-like projections called microvilli, and that's called brush border epithelium. Such epithelium is seen mainly in the GIT. The purpose is to increase the surface area for absorption. So in GIT means large and small intestines, and in the gallbladder, also in the ependyma of the cavities of the CNS, lining epithelium of ventricles. This has brush border as well as ciliated epithelium. So ependymal cells are peculiar. Then in PCT and DCT also you find is brush border epithelium. Then simple columnar ciliated epithelium. The examples are mainly in the fallopian tubes, you can write there, and in the secondary, tertiary bronchus, and in the bronchioles also. In fallopian tubes, not all the cells are simple columnar ciliated, because in fallopian tubes also there are few basal cells called the PEG cells. They are secretory cells. Then examples of pseudostratified ciliated columnar epithelium is the airway conductive passage right from the nasal chambers, the nasal cavity, nasopharynx, trachea, principal bronchus. Similarly, it also lines the ejaculatory pathway, means from the epididymis, vas deferens, ampulla of the ductus deferens, seminal vesicles, ejaculatory ducts, then membranous urethra, penile urethra. All this is being lined by pseudostratified ciliated columnar epithelium. While in the epididymis, vas deferens, seminal vesicles, there are patchy cilia, means few cells with cilia, but those cilia are actually stereocilia, means not of functional value. Then examples of stratified is transitional epithelium, which is also called urothelium, which lines the passage of the urinary outflow right from minor calyces, major calyces, renal pelvis, ureter, urinary bladder, and prostatic urethra. All this is lined by transitional epithelium and the female urethra also, except the terminal portion, because terminal portion of male and female urethra both have this lining of stratified squamous epithelium. So transitional epithelium is also called urothelium. Then talking about stratified columnar epithelium, this you will find in the upper portion of the anal canal, the portion of anal canal above the pectinate line, and also in the lining epithelium of the large exocrine ducts of salivary glands like Stenson's duct, Wharton's duct. Now talking about stratified cuboidal epithelium, this is rare and that's why its example is important. So remember that stratified cuboidal epithelium is seen in the non-secretory portion, means the exit pathway of the sweat glands. Then talking about stratified squamous epithelium, which may be keratinized or not keratinized. So the stratified squamous keratinized epithelium covers the entire human body from outside, that is called skin. That may be hairy or not hairy. That may be thick or thin. That's a different classification. But the same epithelium, when it invaginates through the orifices present on the body, then it becomes stratified squamous non-keratinized. Like the lining epithelium of the oral cavity, lining epithelium of the tongue, the tonsil, the hard palate, soft palate, gingiva, floor of the mouth, pharynx, esophagus, all is bi-stratified squamous non-keratinized. Similarly, vagina, anal canal below to the pectinate line, the terminal portion of the urethra in male and female, all it's by stratified squamous non-keratinized epithelium. Even the lining of the vestibule of the nose, vestibule of the female external genitalia, terminal openings of the latissiferous ducts at the nipples. So all these orifices at their termices are also lined by stratified squamous non-keratinized epithelium. So these are the examples. Actually, what I'm doing is making you learn and making you prepare, because this exam is already over. This will help you in your further exams. Here you're writing about the types of epithelium. You need not actually write the examples because they have not asked the examples. But it is of course desirable to see the answers with examples, and that fetches you good marks. Then derivatives of the second pharyngeal arch. This question again is a question from general embryology portion. So ideally this should have been asked in paper 1. It is simple. You just have to describe the skeletal, the muscular derivatives, the blood supply, and the cartilage. So the cartilage of the second pharyngeal arch is called the Richards cartilage. The nerve of this arch is called the facial nerve, and the artery which arises from this arch is the stapedial artery. Now talking about the skeletal derivatives, that includes the stapes bone, the styloid process, stylohyoid ligament, lesser corn of the hyoid, and the upper portion of the body of hyoid. These are the skeletal and cartilages formed. Then including the muscles here, you should know that all the muscles of the facial expression are formed from this second pharyngeal arch, and that together is called panniculus carnosus in lower animals. Except there is one muscle which is not supplied by facial nerve, and that muscle is levator palpebrae superioris. That is being innervated by the third cranial nerve, oculomotor nerve. Apart from these muscles of facial expression, the other muscles developing from this arch are stapedius muscle, stylohyoid, posterior belly of the digastric, and the muscles of the pinna and the platysma, although they are also included in the muscles of facial expression. Remember, pharyngeal arches is a must to read before going for the exams. Talking about boundaries of the epiploic foramen, you can simply draw a diagram to explain this, that this foramen actually communicates the greater sac and the lesser sac. It's present below the free border of the lesser omentum. So the transverse level of this foramen lies at the level of T12 vertebra. So you can write that what lies in posterior relation is the T12th vertebra. The right suprarenal gland also lies over to that, and the inferior vena cava. All these are in posterior relation. Actually speaking, this foramen doesn't has clear-cut boundaries. So here the boundaries actually means the structures lying anterior, posterior, superior, inferior. That's how you have to describe the boundaries. So the anterior boundary, you can say, is the anterior relations, right? So anteriorly it's the lower free border of the lesser omentum, which contains the portal vein, hepatic artery, and the bile duct. And superiorly it's the caudate lobe of the liver. And inferiorly it will be the first part of the duodenum and the horizontal part of the hepatic artery running above to that. You can simply draw a diagram to explain this. Now talking about splenic circulation. Splenic circulation, actually I have already explained in one of my question papers regarding the pre-university exams. I will upload the link to that question paper in the description of this video, and in the comment section you can watch it from there. Let me tell you, people simply write that the splenic circulation is by splenic artery and splenic vein. That is not correct, because they could have asked simply the blood supply of spleen instead. So while asking about splenic circulation means they are asking you the intrasplenic circulation. So that's about the open and closed circulation. The spleen enters the hilum with its 5 or more branches, and how it forms the trabecular arteries, then penicillar arteries, passing through the white pulp, the pals or Pacinian corpuscles, then epithelioids, then reaching down to either drain into the venous sinusoids or opening into the red pulp, that's called cords of Billroth. So the epithelioids opening into the red pulp or the cords of Billroth will be counted as the part of open circulation, while those epithelioids opening into the venous sinusoids, they will be a part of closed circulation. But ultimately, the efferents, the venules, they're emerging from the venous sinusoids. So the open blood within the red pulp will also be brought back to the venous sinusoids, and from there there will be exit pathway. So that's how you can describe the splenic circulation. For more details, you can watch the video I have attached. Now question number 4, that's multiple choice questions. First one here is, the appendix of testis is a remnant of mesonephric tubule, mesonephric duct, paramesonephric duct, urorectal septum. This I believe I've already explained it somewhere, either in paper 2 part 1 or paper 2 part 2. I think in paper 2 part 1 I've explained about this. So the answer here is paramesonephric duct. The cranial remnant of this duct in males is called appendix of testis, also called hydatid of Morgagni. And the caudal remnant of this duct in males is called the prostatic utricle. Yes, now I remember I have explained it in paper 2 part 1. Paramesonephric duct is also called Mullerian duct. Then Gartner's duct is derived from genital tubercle, mesonephric tubule, mesonephric duct, paramesonephric duct. So this is a remnant of mesonephric duct in females. Mesonephric duct is also called as Wolffian duct. So this Gartner's duct you will find as a content of broad ligament in females. MCQ number 3, the primordial germ cell originates from epiblast cells, hypoblast cells, yolk sac, or primitive node. So they've asked about these primordial germ cells, which are migratory amoeboid cells which migrate and reach to the developing gonads. The answer to this question as provided by the university was choice A, that is epiblast cells. However, many professors, they were not satisfied with this answer and they claim that yolk sac is a better option. I'll tell you why. You know, there's this blastocyst which undergoes implantation, and that had the cluster of cells at one end, and that's called the animal pole, which later modifies to form a bilaminar embryonic disc with an epiblast and hypoblast. Then there is this process called gastrulation that takes place. So the epiblast cells form the primitive streak, that is the first step of gastrulation, and from there those epiblast cells migrate in between to form the intraembryonic mesoderm. So that's how a trilaminar embryonic disc is formed. Now each of these cells here, they are pluripotent or multipotent. They have yet not decided which organ they will form. Few of these epiblast cells migrate and get settled in the wall of the primitive yolk sac, which is formed by extraembryonic mesoderm. And after the splitting of the extraembryonic mesoderm, that's formation of extraembryonic coelom, this yolk sac is now called the secondary yolk sac. And this secondary yolk sac, you must have read, forms the vitellointestinal duct. So it communicates to the midgut loop. So these primordial germ cells from the wall of the yolk sac migrate via the amoeboid movements, reach to the midgut loop, and then further to the dorsal mesentery. And the dorsal mesentery, is a fold of peritoneum, and that peritoneum also covers the intermediate mesoderm that forms the gonadal ridge on the medial side of the nephrogenic cords adjacent to the lower thoracic or upper lumbar segments. So there are the future gonads being formed by the gonadal ridge, and these amoeboid cells get impregnated within the developing gonads. and this process of migration is happening in the early fourth week of embryogenesis. So this is what happens with the primordial germ cells. Now if you read it from the books, you will find that some books don't even mention about the epiblast cells. They simply write that the primordial germ cells are being formed in the walls of the yolk sac. However, in few embryology books, especially the Langman's embryology, the first line they have written is that the primordial germ cells are derived from the epiblasts. So it's not wrong to say that they are derived from epiblasts, but remember that epiblast cells are pluripotent. They have yet not decided their fate, but the cells of the epiblast which migrate and settle around the wall of the yolk sac, they are actually destined to form the primitive germ cells. So if they would have not mentioned the yolk sac as one of the choices, then epiblast would have been the correct answer without any debate. Or if they would have written the walls of the yolk sac along with the epiblast cells, then wall of the yolk sac would have been a more precise answer. That's what many faculty have this opinion, and let me tell you, many faculty even have given +1 marks to those students who have marked yolk sac as the answer, and the university gives this right to professors to check the MCQs on their own opinion. MCQ number 4. The intervertebral joint is an example of synostosis, synchondrosis, syndesmosis, symphysis. Answer here is symphysis. Until unless specified, intervertebral joint is considered to be a joint between the two vertebral bodies. Although there are 3 intervertebral joints between two vertebra, at least minimum 3 joints, and I believe you should know this, that the posterior element of these vertebrae, that's called the neural arc, that also has projecting above and below as the posterior articulating facets which join with the vertebra above and vertebra below to form the zygopophyseal joints. So they are also intervertebral joints, but they are plain synovial joints. But because they have not given synovial joints here, or the plain synovial joints, so that option otherwise also is cancelled out here. What remains is symphysis. Now that means the intervertebral joint between the body of vertebrae is having a fibrocartilaginous disc in between, and the articulating surfaces of these body of vertebrae, they are lined by hyaline cartilage. So that's the structure of a secondary cartilaginous joint, and secondary cartilaginous joints are also called symphysis. These are unpaired joints present in the median plane of the body, that includes manubrosternal joint as well and pubic symphysis as well. Remember, syndesmosis is a joint without any articular surfaces, simply the two bones held by a fibrous band or a ligament. The example of syndesmosis is the inferior tibiofibular joint or the intermediate radioulnar and tibiofibular joints. With the help of those, interosseous membranes, these two bones are joined. That's syndesmosis. Then synchondrosis is another name for primary cartilaginous joints. Symphysis is secondary cartilaginous joints. And synostosis is simply fusion of the two bones. MCQ number 5. Tensor fasciae lata is supplied by posterior division of obturator nerve, anterior division of obturator nerve, inferior gluteal nerve, superior gluteal nerve. So remember, this tensor fasciae lata is a muscle of the gluteal region which is meant to tension, means strengthen the iliotibial tract, and iliotibial tract is the lateral thickening of the fascia lata. So this muscle arising from the anterior superior spine up till the iliac tubercle on the outer lip is called tensor fasciae lata. This muscle is innervated by the superior gluteal nerve, and this nerve supplies two other muscles also, that is gluteus medius and gluteus minimus, and this nerve runs in between these two muscles. Question number 6. The medial end of inguinal ligament is attached to pecten pubis, pubic crest, pubic tubercles, pubic symphysis. all these terminology is related to the medial end of the pubic bone. Pubic symphysis is the surface which articulates with the similar surface of the opposite bone to form a secondary cartilaginous joint. That's pubic symphysis. Pubic tubercle is the answer here. It is a tubercular elevation seen on the body of pubis, lateral to the pubic crest. Pubic crest is the upper surface of the pubis, and pecten pubis is the flattened surface of the iliopubic ramus. It actually is a triangular area from where this pectineus muscle arises. So the answer here is pubic tubercle, while the lateral end of this inguinal ligament is attached to anterior superior iliac spine. MCQ number 7. The calcaneocuboid joint is of the following type: plain synovial, saddle, ball and socket, hinge. So remember, calcaneocuboid joint is an example of saddle joint, saddle variety of synovial joint. Other examples of saddle joint include the sternoclavicular joint, patellofemoral joint, incudomalleolar joint, joint between first metacarpal and trapezium carpal bone. So these are few examples. Remember it for your future MCQs. Left gonadal vein drains into inferior vena cava, portal vein, left common iliac vein, left renal vein. So remember that the left gonadal means left testicular and left ovarian vein. They drain into the left renal vein. And this communication of left testicular vein into the left renal vein is nearly at 90 degrees. So that becomes a reason for left varicocele being common. Question number 9. Urorectal septum divides cloaca into rectum and urogenital sinus, bladder and allantois, rectum and bladder, hindgut and bladder. This urorectal septum I described in paper 2 part 1, where I was describing about the development of prostate. So remember that urorectal septum is a vertical septum descending downwards and dividing the cloaca into a ventral and a dorsal portion. It divides the cloaca into rectum and urogenital sinus. The answer here is A. MCQ number 10. The great cardiac vein accompanies anterior interventricular artery, posterior interventricular artery, right coronary artery, left coronary artery. It's a simple question. It is a large vein which accompanies the anterior interventricular artery. This great cardiac vein runs into the left coronary sulcus along with the left circumflex coronary artery, and it drains into the left end of the coronary sinus. That's great cardiac vein. So that's all in this question paper. Good luck, guys.